about the thyroid dysfunction in kids with Down syndrome. And I'm going to give you a background about the association between the thyroid disorder and Down syndrome. So as you know, Down syndrome is the most common genetic cause of moderate to severe intellectual disability. It's associated with a number of medical conditions, and the thyroid is one of them. The prevalence of the thyroid dysfunction in kids with Down syndrome has been estimated to be around 15%. And if you compare it to the general population, it's almost more than 100 times. The general population prevalence is 0.135%. Hypothyroidism is the commonest one and the one that we are really need to be diagnosed and treated. And as we know, most of the people that we know have hypothyroidism, they do have a subtle presentation before the diagnosis. And it's more challenging in kids with Down syndrome because there's an overlap between the signs and symptoms of hypothyroidism and the clinical feature of Down syndrome, namely the impaired intellectual development in young children, the decreased linear growth, dry skin and dentation abnormality, and decreased physical activity. So hopefully by the end of this session, we'll be able to outline the spectrum of thyroid dysfunction in children with Down syndrome, including congenital hypothyroidism, autoimmune hypothyroidism, subclinical hypothyroidism, and this is going to be the main focus of today's presentation because it is a common cause of referral to the endocrine center or services. And the last is going to be hyperthyroidism. Then I'm going to move and review and compare different national guidelines on assessment, screening, and the medical management of thyroid disorder in children with Down syndrome. Mainly focus going to be on the Ireland, UK, US, Australia, and Canada. And then I'm going to present and share with you our SKMC, Sheikh Khalifa Medical City Clinical Practice Guidelines in evaluating and managing thyroid disorder in children with Down syndrome. So a quick review of the function of the thyroid gland. As you know, the thyroid gland itself is located on the neck just below the voice. Oops, here we go. It's located in here, and the main function is to regulate and maintain a steady level of the thyroid hormone through the phases of the growth. And because of the importance of the thyroid hormone, this has been under the control of the hypothalamus and the pituitary gland. So if the thyroid is under functioning, meaning that we have too little of the growth hormone, the hypothalamus gonna alert the pituitary gland to secrete the TSH, which is the thyroid stimulating hormone, which gonna force the thyroid gland to produce more of this hormone. So this is the positive feedback, while if we have the thyroid gland that it's overactive, meaning that we have a lot of the thyroid hormone in the circulation, this is gonna induce a negative feedback at the level of the hypothalamus as well as the pituitary gland. So the thyroid hormone production can be downregulated. So why thyroid screening? It's really indicated for kids with Down syndrome. And the rationale, if you recall, if you have to implement any screening, you have to have 4 criteria. And let's find out if all of these criteria is really met in this population. The high prevalence of the thyroid disease, and we did say that, it's more than 100 times than the general population. So criteria number 1 is met. It's difficult to diagnose if we just base it on the clinical, and it is true because it's masked with the phenotype of the Down syndrome. And then number 3 is that if you don't intervene, there is an adverse medical effect associated with untreated or lately diagnosed cases. And the number 4 is the availability of a widely cost-effective testing is very cheap, and the treatment as well is cheap. So all of the 4 criteria has met, which mandate that these kids really deserve to have a screening established. So what is the spectrum of the thyroid dysfunction in kids with Down syndrome? As I'm going to take you through them. So we're going to start first with the congenital hypothyroidism. So as you know, in UAE, the program has been established in 1998. Sorry, 1998, where the newborn screening has launched the newborn screening for congenital hypothyroidism. And in this, we do have the kids by the age, the newborn by the age of 2 to 3 days, they will have the blood collected and sent to the center where they do have the TSH. So here in UAE, the newborn screening has been launched in 1998 and it's based on the TSH of more than 40, indicating that the patient or the baby has a positive newborn screening. So the baby will be referred to the endocrine center, including Abu Dhabi, Sharjah, or Dubai. And kids with Down syndrome had been found that they have 28 times more evidence of hypothyroidism than the general population. And it's more common with kids with gastrointestinal abnormality. For the subclinical hypo, what even make it more challenging, they have been found that although the cutoff for the newborn screening is 40, kids with Down syndrome, they tend to have a lower limit. So these cases are going to be missed even if you've done the newborn screening. So it's a mandate that we need to do it at around the 3rd or 4th day again. The transient form of hypothyroidism has been also existed, where we, if you notice that from yesterday's slides, a lot of kids, they do have cardiac and GI abnormalities. It causes them to have more of iodine exposure, and this will cause a lot of influx on the thyroid. The thyroid is going to absorb a lot of iodine, which is going to shut their thyroid hormone production. So these kids will have a transient form of hypothyroidism. The next entity is the autoimmune thyroid disease. They have higher prevalence than the general population, where we could see that the general population based in the US group, for the kids between the age of 12 to 19, it has been estimated at 13%, while Down syndrome kids, they do have it up to the age of, up to 30% of them will have autoimmune thyroid disease. The prevalence of anti-TPO antibody is up to 30%, and I think Dr. Abir has gave us the Eastern region experience yesterday, and the figures were around the same number. The thing that we need to keep in mind that even if the kid has normal TPO antibodies early in life, the cumulative incidence of developing autoantibodies going to increase with age. It's been well documented that those with autoantibody positive thyroid status, they tend to convert to hypothyroidism more than those with antibody negative. And the conversion rate is about 4.3% in kids with positive autoantibodies, comparing to 2.6% for those with a negative autoantibody. And the risk of progression on those with autoantibodies is similar to the non-Down syndrome patient. And although most of the cases has been diagnosed at the age of, after school age, which is around 4 to 5, there was a few cases of such hypothyroidism attributed to autoimmune etiology have been diagnosed during infancy as well. This is a graph where it showed the relation of the age and the progression of the hypothyroidism. So this is a 28 patient with Down syndrome who have been followed, and you could see that this is age around the age of 1 year during the first year of life, and this is the cumulative percentage of patients developing hypothyroidism. And you could see that as the kids get older, the incidence of having hypothyroidism is increasing. So the clinical presentation, how it is different from the other non-Down syndrome population. As I said before, it's usually it's overlap, and it's hard to be difficult because it's overlap with the clinical symptoms of Down syndrome, and most of them is diagnosed by screening. In the non-Down syndrome population, well documented that it's more in female than in male, while in here it's equal between male and female. And in more than 85% of them, there is no goiter, and we do see that most of the kids who present with Hashimoto and they don't have Down syndrome, they do come with the goiter. And there is an entity where the kid might flip from hypothyroidism to hyperthyroidism, so we label them as hashitoxicosis. A minority of patients even will make it more complicated, where they will tend to move from hyper, and then euthyroid, and will flip over again. And this is an entity that has to do with the thyroiditis itself. So the more challenging, I would say, and the one that creates a lot of anxiety with the pediatric or primary care physician is the thyroid dysfunction in relation to what we call subclinical hypothyroidism. So by definition, subclinical hypothyroidism implies an elevated TSH level in the presence of normal T4 and T3. And it's very common, not only in kids with Down syndrome, in general population. Prevalence is around 25 to 60%. If you compare to general population, 4 to 8%. The etiologies remain unknown. However, there is many theories. One of them, and the commonest, is the thyroid autoimmunity. Number 2 is immaturity of the hypothalamic pituitary thyroid axis, immune modulation, and other. So the thyroid autoimmunity have shared with you in the previous slide that the autoantibodies status in kids with Down syndrome is as high as 30%. And those who have these are at higher risk of continue to have the hypothyroidism, but not all of them. So we have to keep it in mind. A follow-up of 70 patients with Down syndrome in Italy has revealed that those who have subclinical hypothyroidism, where T4 is normal, TSH is elevated, up to 27% of them normalize their TSH. 66% of them remained mildly elevated, required no intervention. 4% progressed to overt hypothyroidism, so treatment was initiated, and 3% had flipped to the hyperthyroidism. So the studies had concluded that most of the Down syndrome with subclinical hypothyroidism who progressed to over hypothyroidism had a positive anti-TBO. So we have to keep it in mind. Yes, anti-TBO positive status is really important, especially with the subclinical hypothyroidism, and it's good for the counseling, the family, the importance of maintaining a regular follow-up with your primary healthcare physician. However, there is no agreement on the expected rate of conversion, so I cannot really give them a prognosis if this kid's going to have the disease in a year, 3 years, or 10 years from now, but the surveillance is really warranted in here. The second theory is that immaturity of the hypothalamus pituitary thyroid axis, it's self-limiting and it's mainly delay in maturation, and it's going to resolve usually by the age of 2 to 3 years. This is the more, it has been newly introduced, and I find it really interesting. Interferon alpha, especially type 1, has been shown to regulate the synthesis and the secretion of the thyroid hormone. And with the introduction of the immune modulation, including INF alpha, they noticed that a lot of people or patients been on this treatment, they develop thyroid problem. So which make them try to link why kids with Down syndrome might have thyroid problem. And then they discovered that the interferon alpha receptor 1 and receptor 2 are located in chromosome 21, which means these kids, because they have an additional chromosome, they tend to overexpress these receptor, which means they will be more responsive to the INF type 1, causing a thyrotoxic effect and hypothyroidism. The last theory, which I would say it's applicable even for the non-Down syndrome, the non-thyroidal illness, meaning that we know that the thyroid, the main function is to regulate our metabolism. And during acute illness, we need to down-regulate and redistribute the resources between our body cell and function. So the normal response is that the TSH gonna drop, your free T4 is gonna be dropping because you don't need them at that point. But then, as soon as your body is gonna recover, there's gonna be transient increase in the TSH, which causing restoration of our normal free T4. If it happened, this kid has presented to your office, and you did the thyroid function test at the time when he's recovering from acute illness, even if it is simple URTI, you might find that the patient have a TSH, is mildly elevated, but normal free T4. So think about it as it might be a non-thyroidal illness, and don't start the patient on a treatment that might be on long-term, and no one's gonna be reconsider weaning the patient from this medication. And the last is the random TSH variation. It has been now proven that TSH level tend to fluctuate during the day. So if you want to do it almost around the same time, morning, afternoon, or evening. And have been found that up to 26% change in mean might occur if you did the thyroid function test at different time. meaning that this child might have TSH of 6, which is abnormal, high elevated. 26% of mean difference, gonna drop it down to 4, which is completely normal. So keep it in mind, and don't put the patient in a treatment before you confirm the diagnosis. So subclinical hypothyroidism, does it really cause the symptoms of patient presenting with the if you think this is hypothyroidism, and if the treatment is really beneficial? One study have shown that kids who are less than 4 years of age, if they have TSH elevated, they will have deceleration of their linear growth. And another researcher has recommended that it's better to put the patient on the treatment, even in the mild cases, to prevent the progression to overt hypothyroidism. But now we have more data to support that. With the close observation, close monitoring, I think putting a treatment as a trial off, it's not really indicated. This is one of the study that I just shared it with you. So here is the kids who have euthyroid, and this is the kids who have hypothyroid. So this is the 8 kids with Down syndrome. 8 kids with Down syndrome has been matched for the sex and for age. And they have compared their linear growth. And you could see that kids with hypothyroidism tend to grow at a lower rate. Soon as they put them on a treatment, they had a nice catch-up of their growth. And this is the rationale of introducing the thyroxin early to promote the child growth. And this is specific for kids with Down syndrome. So we have to agree that treatment of subclinical hypothyroidism as per today, there is no clear consensus on which of these patients really need a treatment and what cutoff level of TSH should be used. And argument in favor of treatment, as we did discuss it before, there is no lack of adverse side effect from the thyroxin itself, and there is a possible beneficial effect in the growth and development of the affected child. So evidence of treatment in subclinical hypothyroidism, although it is poor, but the lack of the evidence does not necessarily imply the lack of benefit. So we have to discuss each case individually. And subclinical hypothyroidism, as summary, based on the best evidence available, treatment should be indicated in one of the following. If the TSH level is more than 10, number 2, if we have a persistent mild TSH elevation, which it depends on the local lab, but most of them will agree if it's above 5, it's abnormal. So between 4.5 to 9.9, and you have a goiter, which is clearly rarely in kids with Down syndrome, up to 15% only. If they have positive anti-TPO, because we did show that they tend to convert to hypothyroidism with time. And for kids who are less than 2 years of age, and why is that? Because this is the most important period where the child neurodevelopment is happening, and you don't want to sacrifice the treatment knowing that has no side effect. But you have to counsel the family that the trial of therapy should be considered around the age of 3 years. Hyperthyroidism is the fourth of the spectrum of thyroid disorder in Down syndrome. It's more common than in general population. Prevalence is up to 3%, and most of the time it's autoimmune mediated and has no female predominant if we compare it to the non-Down syndrome population. Commonly reported symptoms include heat intolerance, irritability, weight loss, tachycardia, and palpitation. And the treatment is similar to the non-Down syndrome. The first line of treatment is the antithyroid medication, namely methimazole or carbimazole, plus or minus beta blocker to reduce the sympathetic symptoms. Relapse rate, we know that up to 30-60% of kids whom completed the 2 years of treatment will have a relapse. And the complication from the medication itself is up to 30%. Of these, 30% the kid need to be off treatment because of life-threatening complication including hepatitis. Definitive therapy, so it's mainly radioactive iodine and the thyroidectomy. Both of them available. However, the thyroidectomy, it needs to be done in a center where they are familiar and they've done a lot of surgeries and such short neck. Not only this, if you recall from yesterday, the orthopedic sessions, that we did have a limitation in here because they tend to hide craniofacial abnormality, and atlantoaxial subluxation is one of the risks for any anesthesia setting where there is a risk for the patient and the surgery as overall. So it might affect the success rate of the surgery. So let's quickly go through the national guidelines for thyroid assessment for children with Down syndrome. I'm gonna discuss, as I said, the UK, Ireland, US, Canadian, and the Australia. So gonna focus on when they are gonna do the thyroid function test, and if they will order the antibody testing, and what treatment they will offer for subclinical hypothyroidism. So here is based on the countries like Ireland, UK, US, Canadian, and the Australia, and then the time when they're gonna do it. So this is birth, 6 months, and then on yearly basis. The one that we are used to, I would assume, based on the American Academy of Pediatric, mainly the US and the Canadian, they adopted this, where they tend to do it at birth, 6 months, and then on yearly basis. So this is the Canadian and the US. While the Australian, they will do only at birth, they will skip 6 months, and then they will move to the 1 year, and then they're gonna do it on yearly basis. Ireland gonna do it at birth, 2 years, until the age of 5 years, and then they're gonna skip every 2 years. If you go to UK, they do birth 1 year, and then every 2 years. So there is a difference between one country to another, but the idea, if you recall the previous slide, you might be missing a lot of kids during the 6 months, because as we said, subclinical congenital hypothyroidism is really common, and a lot of kids with Down syndrome might have level outside the newborn screening, and at least around the 6 months of age, this is a time where it's necessary to be done. So if you move to the next one, do we really need to do thyroid autoantibodies on all kids with Down syndrome if we are checking their thyroid function test? The Irish and the UK, they do recommend performing the thyroid antibody testing, and how frequent with each thyroid testing. While the US, Canadian, Australian, they don't refer to these autoantibody testing, so it's individualized based on their local center. Treatment for subclinical hypothyroidism, all guidelines are lacking in evidence regarding the management of subclinical hypothyroidism until this point. UK, they did mention that TSH more than or equal to 10 warrant a treatment, but it's not a mandatory, while TSH less than 10 or the presence of thyroid autoantibodies in the absence of clinical symptoms does not really require treatment, but should be monitored with more frequent thyroid function tests. The rest of the countries has declined from reporting any evidence for treatment of subclinical hypothyroidism. Now, I'm going to share with you our SKMC clinical guidelines for thyroid assessment and management of children with Down syndrome. And I'm going to do exactly the same. So the thyroid function test, when, and autoantibodies, when it's going to be required, and what to do with them. And then the subclinical hypothyroidism evaluation and management. So thyroid function test, mainly we will request TSH and the free T4. And it should be done at birth, ideally after the 2nd day of life, to avoid the normal surge of TSH that's completely normal during the first 2 days of life, and plus the newborn screening. At 6 months of age, it's going to be repeated again, even if the first one is normal, and then annually throughout the childhood. If TSH is borderline at any point, meaning that TSH between 4.5 to 9.9, then thyroid function test should be checked every 4 to 6 months and refer most likely to the endocrine clinic or to the Down syndrome facility where they do have their own surveillance. If TSH has been more than or equal to 10, to recheck thyroid function test in 1 to 3 weeks and assess the result based on that. I'm going to discuss this later on. Thyroid antibody, we are following the UK guidelines, so it's at 6 months of age and then annually with thyroid function test, because based on that graph, the conversion rate is high. The thyroid autoantibody is going to evolve with time and it's going to be helpful for the prognostic counseling later on. Subclinical hypothyroidism, if TSH more than 10 and 2 confirmed readings, prefer to be done 1 to 3 weeks and make sure that the kid is completely in his normal baseline, so he's not having URTI, not recovering from an illness. We could rely on this and start the kid on treatment. A treatment should be considered if TSH were persistently borderline, meaning TSH less than 10 but more than 4.5, with positive anti-TBO or with a goiter, and for children less than 2 years of age. So we'll take you through the algorithm in here. So thyroid function test, TSH and the free T4 mainly. Normal thyroid function test. This send the patient for recheck thyroid function annually, and don't forget the 6-month recheck again. Abnormal thyroid function test, TSH of more than 10 with low T4. This is no question. This is not a subclinical hypothyroidism. This is a hypothyroidism. Start the patient on treatment and recheck thyroid function test in 4 to 6 weeks to assess the adequacy of the thyroid hormone replacement. If TSH is more than 10 and we have normal T4, this is subclinical hypothyroidism. So recheck thyroid function test plus add anti-TBO in 1 to 3 weeks, in a period of 1 to 3 weeks, and make sure that the patient is completely healthy. And if TSH is more than 10, or you might have a normal thyroid function test, or you might have TSH between 4.5 or 9.9. This is the way where we have to think of. If the TSH on the second confirmatory sample has been more than 10, start Thyroxin therapy. If the TSH has been normal, you could send the patient for the annual check. If the TSH has been borderline, back to the second surveillance. So if we start with have a borderline thyroid function test, recheck it in 4 to 6 months. Don't rush it. Don't do it in monthly basis or 3 months. 4 to 6 months would be more than enough. Most of the literature will refer to 6 months. I added the 4 to 6 months just because I want to increase the awareness of our population, the importance of doing this. If I'm going to see them once every 2 years, they might miss that appointment. I will end up doing only once yearly. So make it just to customize it for our population until they get the sense of the importance of doing the thyroid function test. I would rather to do it in 4 months. So by this, I make sure that I will see this kid every 3 months. I will monitor his growth. And then if it is normal, so annual, if it is, again, borderline, I will put him on the same cycle. Every 4 to 6 months, going to be repeated. So I'm going to conclude at this point, and I would conclude by as we had discussed, thyroid dysfunction occurred in increased frequency in kids with Down syndrome comparing to the general population. And because of the non-specific nature of the hypothyroidism symptoms in Down syndrome and the overlap between the symptoms with the phenotype of Down syndrome, the screening is really highly indicated. Thyroid function should be followed closely, whether or not the thyroid autoantibody present. And different guidelines had make reference to the thyroid screening, as you could, we have reviewed it. And the management was not really covered well in here. Literature remained divided in the optimal detection and the management of subclinical hypothyroidism. And this is true even for children with no Down syndrome. Presence of the anti-TBO positive status predict the risk of developing to overt hypothyroidism. And patient with TSH of more than or equal 10 confirmed twice should be started on Thyroxin therapy without any delay, even with the normal T4. Patient with mild TSH elevation, which is less than 10, need closer surveillance and may require treatment eventually. And by this, I'm ending my presentation. Thank you.